Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Shaffer, and I'm pleased to bring to you an interview with Francisco Xavier de Araujo and Giovanni Ferreira. Francisco is a physical therapist from Brazil. He also lived in Italy for 4 years, where he completed training in advanced orthopedic manipulative physiotherapy at the International Maitland Teachers Association, also called IMTA. Upon returning to Brazil, he went on to complete advanced master's training. Currently, he is working both as a clinician and lecturer, and is in the final stages of finishing a doctorate of science. Giovanni is also a physical therapist from Brazil with both entry-level and advanced master's training. Additionally, he moved to Sydney, Australia in 2017 to pursue a PhD with Professor Chris Mayer at the Institute of Musculoskeletal Health, which is located at the University of Sydney. His research focuses on both treatment and prevention strategies for low back pain. We invited Francisco and Giovanni to the podcast because they recently co-authored a paper published in the Journal of Manipulative and Physiological Therapeutics titled Autonomic Effects of Spinal Manipulative Therapy, Systematic Review of Randomized Control Trials. Without any further delay, let's get to the interview. Francisco, welcome to the podcast. How are you doing today?
I'm doing well, and I'm very happy to be here. Thank you for inviting us, Steve.
You are very welcome. And you said us, and as I indicated in the introduction, we also have with us Giovanni. A warm welcome to you as well. How are you today?
Thanks, Steve. Thanks for having us. I'm well. I'm fine, thanks.
Before we fully dive in, let me first say that I am super excited to have you both here on the podcast. That's because this happens to be one of my favorite topics. It's one of my favorite clinical and academic topics. So when I saw the paper that you had written, I was not only very pleased to read it, but I was, in fact, a little bit jealous that I had not written it myself. So kudos to both of you.
Thanks, Steve.
Thank you. Thank you very much. We are very proud.
So regarding the overall topic at hand for today's interview, let's get started by asking, what was it that caused you and your colleagues to become interested in the overall relationship between the application of orthopedic manual therapy techniques to the spine and the autonomic nervous system?
So it has a long story to explain these interests. Traditionally, orthopedic manipulative physical therapy techniques have been associated with treating joints out of place. And historically, this concept probably originated from the famous bone setters. And it's interesting that these explanations are widely accepted, but the current literature does not support their validity. I think a great example to illustrate that is that even when therapists try to apply a technique at a specific segment, they can't. There's also an issue with the low reliability of manual examination to find the specific level to be manipulated or treated. Another aspect is that after you apply a manual therapy technique, there is no change in joint position. And furthermore, the clinical effects of manual therapy interventions, regardless of whether they are tailored to the clinical presentation or just a generic technique, the effects are similar. And despite all these topics, you will still have good results with this technique. So clearly, there must be something else going on. Maybe other mechanisms that could explain what we see in clinical practice. And that is when some very smart people started talking about the role of the central nervous system in mediating these effects of manual therapy techniques. And for example, you have the model developed by Joel Bialowski that postulates that a cascade of neurophysiological effects mediated by peripheral, spinal, and supraspinal mechanisms exists. And the sympathetic nervous system has a role in this cascade of neurophysiological events that led to spinal manipulative therapy-induced hypoalgesia. So we are firstly interested in diving deeper into these possibly neurophysiological effects of monotherapy, and started to see multiple trials trying to investigate different treatment approaches and measuring outcomes, and lots of them examining outcomes related to the autonomic nervous system. And this is the long story that explains this idea of doing this systematic review.
It's a long story, perhaps, but also a good one. And you, of course, appropriately mentioned that there are all of these studies that have been done before you. And of course, that's why you can do a systematic review. But there have also been reviews done on this topic. So what did you do with this review that was different from some of the other reviews that came before it?
Yes. Are you sure? Are you correct? There are two important systematic reviews that have been published previously. I think a very important review was the one led by Anina Schmid, published in Monotherapy in 2008. For those who might be interested, the review's title is Paradigm Shift in Monotherapy, Evidence for a Central Nervous System Component in the Response to Passive Cervical Joint Mobilization. The title is very catchy and makes you think about the complexity around the spinal manipulative therapy that goes beyond simply working on joints. And it's an interesting review, but it only included studies that did mobilization and not studies that did manipulations, and only applied to the cervical spine. After that, there was also a review published in 2014 by Kingston and colleagues, which included studies that applied mobilization at the entire spine, but excluded studies that did manipulations. But we think that the most important problem with all these reviews was a lack of assessment of the quality of the available evidence. We knew that there were quite a lot of studies using several different techniques and assessing many different outcomes, like heart rate variability and skin conductance, but no review had examined the quality of the evidence for each particular outcome in isolation yet.
Can I jump in?
Absolutely.
All right. I think one of the important things that we should consider is that in randomized trials with multiple outcome measures, which was the case of the trials that had been included in those previous reviews, you can see that the quality of the evidence for each particular outcome can vary across different studies. And I think there are two important implications of doing this assessment of the quality of evidence for each particular outcome. And for that, we used the GRADE approach, the GRADE framework, for those interested in knowing the name of the framework we've used. And I think the first implication and the first important aspect of using GRADE is that GRADE is important to inform clinicians on the quality of evidence, and the information on the quality of evidence will help you understand how much you can rely on those findings. So, for example, if you have evidence from a specific neurophysiological effect of manual therapy and the quality of evidence is low or very low, that means you can't rely as much in that finding as you can if you end up summarizing and finding out an evidence that's got high quality evidence. So I think it helps you out, determining which outcomes you can trust more, or which summary of findings you can trust more. I think there's also a second implication of that, especially for researchers, because the quality of the evidence will dictate how much more research needs to be done for a specific outcome. So, for example, we know at the moment that there is strong evidence that paracetamol doesn't work for acute back pain. And the quality of evidence for this particular intervention being strong means that the chances of future studies altering these conclusions, they're quite small. So there's not much point in maybe putting a lot of research effort into researching, the role of paracetamol for acute back pain. And the biggest advantage, the way I see this, is that, at the end of the day, you can save everyone's time and research taxpayer dollars. So I think our review is important in this scenario of neurophysiological effects of manual therapy, because we were able to include, like Francisco said, we were able to broaden the scope and include mobilizations such as snags, but also manipulations. But ultimately, the important bit that we did was assessing the quality of each outcome individually using the GRADE framework.
You've both very nicely, of course, outlined that there are all these different studies. There's all of this content that went into the review. And you summarize this very nicely in the flow diagram that's presented in the paper. Can you give us a description of what that flow diagram looks like so that we can understand what type of evidence went into this review process?
Okay, so we searched 5 databases from their inception until March 2014. So the first search returned 2,065 titles, and we identified and excluded 81 duplicates, which then left 1,984 titles to be screened for eligibility. This means we read titles and abstracts of all these studies, and when then excluded 1,900 studies, which left us with 24 trials that we read the full text to determine the eligibility. We ended up including 14 trials at the end of the search, and then in a second step of the search, which involved the screening for other studies in the reference of the included trials, ended up finding another 4 trials that were included. So in total, we included 18 trials in this review. The trials were published from 1993 and to 2013 and had a total of 1,055 participants. Spinal manipulative therapy was delivered to the cervical spine in 10 studies, in the thoracic spine in 5 studies, and in the lumbar spine in 3 trials. 3 studies were done in symptomatic people, and 15 studies were conducted with asymptomatic participants. 12 studies used mobilization techniques, and 6 studies did manipulations.
I don't know if you noticed, Steve, but the searches in our review were done in 2014, but the paper was published in 2019. So I guess there's quite a bit of a gap that's not quite usual in systematic reviews. Let me just explain that. It's actually a funny-ish story. Well, it's funny now, but it wasn't funny back then. So basically, we submitted this review back in 2014, I think, or beginning of 2015. And it literally got lost in the limbo for maybe 3 years. It was not until maybe late 2018 or early 2018 that we heard back from the journal with the acceptance of the review. And during that period, we had gone through maybe 2 or 3 rounds of review. So it was the longest time I've ever had to deal with in terms of submitting a paper and waiting for it to be accepted. So that explains why the searches are not completely up to date, and we certainly missed out a few studies published later than 2014.
Well, to all of us that conduct research and participate in the review process, that is not a surprising story by any means. And I actually had one very similar situation where, if I think back, I was actually the reviewer in that particular instance. And about the same time frame, I think it was 3 years later, I just randomly got this email saying that something had been, re-reviewed or whatever. And honestly, it had been so long, I didn't even remember that I had read it. And I had to go back and look at my records and try to figure out. And, these things happen, I guess, is part of what I'm saying, so not the first time, probably won't be the last time.
You didn't review our paper, did you?
Not to the best of my knowledge, no. I've only reviewed one manuscript for that particular journal, and no, it was not this one. But that would have been kind of funny. So going forward here, you have all these studies, the randomized control trials, the cervical spine, the thoracic spine, the lumbar spine. When you looked at all of the evidence, what were your conclusions from this systematic review?
We concluded that there is evidence pointing toward the existence of short-term sympathoexcitatory effects following passive accessory intervertebral mobilizations, but not for sustained natural apophyseal glides like snags. And there is conflicting evidence regarding the ability of manipulations to elicit sympathoexcitation. The problem is that the quality of the evidence for all outcomes ranged from low to very low, and this happened because studies had high risk of bias. For example, had problems with blinding or had very small sample sizes, and most of them were conducted in asymptomatic people. And this means we need a bigger and better quality studies to really understand what is going on with patients' autonomic nervous system. So we think at the moment the best thing we can do is to be cautious and ask for more good quality science before we adopt a strong position that manual therapy affects the autonomic nervous system. What our review shows is that this is indeed a possibility, especially for passive accessory joint mobilization, but not so much for snags and maybe not for manipulations.
And if we pause for a minute and assume there is a relationship there, what mechanisms do you think could be contributing to orthopedic manual or manipulative therapy techniques affecting the autonomic nervous system?
Well, Steve, this is a very complex question, and there is not a simple answer to it. But let's try. The current understanding of these mechanisms is still lacking and requiring additional and more optimally designed studies to answer this question. In addition, many of the outcomes related to the autonomic nervous system prevent direct measurement. For example, changes in skin conductance represent an indirect correlation of the sympathetic nervous system and the orthopedic manipulative therapy. But changes in pain sensitivity are observed in response to orthopedic manipulative therapy, both at the site of the application, but also at distal sites, indicating the presence of central mediating effects and not just mechanical effects, as was supposed years ago. Although it's not yet clearly established, precisely because of the difficulty of directly measuring some of these outcomes, a possible mechanism is that a model proposed by Bialowski, published in 2008 and updated in 2018. And this model is also based on associated neurophysiological responses and not direct observation of nervous system activity. And this model suggests a peripheral, spinal, and supraspinal mechanisms after some manual approach. Effects related to the autonomic nervous system are included in this model, along with others, and that indirectly implies a supraspinal mechanism. Some authors have postulated that an area of the midbrain, the dorsal periaquedutal gray area, DPEG, is instrumental in invoking this activity. Other authors have used the anatomical explanation to account for this increase in sympathetic outflow, and this theory relates to the anatomical positioning of the sympathetic trunk and the paravertebral ganglia. What's interesting and still a little obscure to note is that an imbalance in the activity of the sympathetic nervous system on a more permanent basis can perpetuate clinical conditions of chronic pain, such as fibromyalgia or complex regional pain syndrome. On the other hand, the acute and transient excitation of the sympathetic nervous system after an orthopedic manipulative therapy, for example, seems to be able to activate these descending pain modulation pathways. That is, sustained increased excitation of the sympathetic system can be a problem. but a quick and transient excitement seems to be part of the hypoalgesia process.
Yeah, and like Francisco said, I think the reason why this happens is not clear yet, but maybe, and we've been trying to get our heads around this confusion because, like he said, it's known that an increased response of the sympathetic nervous system is associated with persistent pain conditions. So what could explain the fact that once you apply a manual therapy technique, you have an increase of the sympathetic nervous system, but that's related to pain relief? Wasn't it supposed to be the other way around? So, and I guess we don't know the answer yet. And what I'm going to say here, there's probably a lot of speculation included, but the answer might be in the fact that when you apply a counter-irritant stimulus to the skin or to the human body, there's quite a lot of reactions that happen. They're mediated by the diffuse noxious inhibitory controls, the DNICs, and some spinal nociceptive processes as well. And that could be related to this counter-irritant process could be related to, later on activating a lot of descending inhibitory pathways that could be responsible for pain relief. And that would explain why, for instance, you see this increase in sympathoexcitation for when you apply mobilization techniques, which involve continuous application of a mechanical stimulus, but not so much for snags and not so much for manipulations as well, because they are not they can't be considered, I think, irritant stimulus, either because snags are supposed to be applied in a pain-free manner, or because manipulations are applied quite quickly. So maybe the body can't pick that up. So that could be one of the possible explanations, but again, just in speculation at this time.
So then potentially you would think that provoking pain could be part of what's beneficial with the technique?
Yeah, I guess I wouldn't call provoking pain maybe, but maybe provoking a nociceptive stimulus that would trigger some, like Francisco said, the neurophysiological cascade of events. But maybe for mobilization, this initial increase in nociceptive activity could be an important trigger for all the repercussions and for all the neurophysiological effects that as Bialowski postulated in his model, that could explain the clinical effects of at least mobilizations.
This is all, of course, super interesting. And as you've both very correctly pointed out, we have the evidence, we have some of the background evidence, and we have ideas and theories, but the true factual, here's what it is, substance just doesn't exist yet. And my hope, of course, is that someday we'll know more about all of this. But for now, the orthopedic geeks among us are left to sit around and try and think about what could be going on. And, I don't have any more concrete answers than you do, but bearing that in mind, as a clinician, I'm an individual who's mostly in an interface where I'm treating patients. And I personally find information like this to be quite helpful. I see autonomic nervous system symptoms in many of my patients. How is it that you think clinicians should look at this type of evidence and then try to incorporate it into their clinical practice?
Thank you for this question, Steve. Firstly, a better understanding of the effects of manual therapy techniques is important to reflect on the clinical reasoning process to understand whether the patients can benefit or not from these effects. And a broader understanding of the effects, for example, that they are not just mechanical, it's important for clinical practice, and we hope that our review can contribute a little to this. Clinicians must implement an individualized clinical reasoning process to identify the most appropriate approaches for each patient. Currently, much has been discussed about the different subclassifications and about a biopsychosocial approach. In this sense, these approaches can be very useful for a group of patients who need these effects. And again, in our review, we did not assess clinical outcomes, but we can imagine that if these techniques promote different effects on the autonomic nervous system, and if this acute influence on the autonomic nervous system can contribute to the activation of descending pain control pathways, this approach may be useful for some patients. I guess that some patients are likely to benefit from these effects more than others. This group of patients who can benefit most is not yet well known, but it's likely that patients with clinical conditions with a clear involvement of the autonomic nervous system may be more benefited. For example, some case studies reported interesting effects in patients with complex regional pain syndrome and also in patients with T4 syndrome, for example. Maybe other clinical conditions are not clearly involved in the autonomic nervous system, but there may be a partial involvement. Some studies suggest that some types of adhesive capsulitis or even whiplash-associated disorders of more complex resolution may present some imbalance in the autonomic nervous system. So maybe these patients will benefit also of these approaches. In addition to these clinical conditions, for patients with any complaints of pain, if the physical therapist understands that he needs a more passive intervention or hands-on interventions, maybe this approach can be also indicated thinking in this activation of neurophysiological effects and the descending pathways of controlling the pain. But it's again important to repeat that of the 18 studies included in our systematic review, 15 included only asymptomatic subjects. So clinicians should carefully interpret our findings, and our review also found no long-term measures. So in other words, within this clinical reasoning process, perhaps these effects should be considered as more immediate and more short-term, and maybe other physical therapy approaches should be more suitable for more lasting changes, such as exercises or maybe education.
To build off something that you said near the beginning of the interview, the automatic assumption then is that, yes, you think there's enough evidence out there to say this topic should be studied further. No, that evidence isn't, perfect. So we need to, for example, see larger studies, more long-term studies, and studies with clinical outcomes.
In our review, we found that quality of the evidence is on this topic, and for these outcomes was low or very low. And that means that there is a lot of uncertainty with regards to what is the real effect of manual therapy techniques on the autonomic nervous system. We saw some very common problem across most trials that we included. For example, reporting of the studies was not very good. Many papers were a bit clunky and had tables that were difficult to interpret. So we would strongly recommend future studies to use the consort statement when reporting results of a randomized trial. And other important aspect is related to the risk of bias. Several studies has problem with lack of concealment allocation or blinding the participants and the assessors, which is very important to guarantee the results of the study are free from bias as possible. And from a clinical standpoint, we definitely need more studies with symptomatic sample. And we also need studies that collect both experimental outcomes, such as activity of the autonomic nervous system, but also clinical outcomes, such as pain and disability, so that we can start beginning to understand whether there is a relationship between autonomic nervous system activity and patient-reported outcomes.
But if you're really interested in investigating mechanisms of treatment, what you really need to do is an analysis method called mediation analysis. So this is the nerd in me talking now. So mediation analysis is a method that allows you to truly understand whether a change in an outcome, and the example here would be pain, can be explained by a change in something else that's believed to be the causal pathway of that outcome. In other words, in simple words, a mechanism of action of the treatment. So if you're interested, if you're as nerdy as me, and you might be interested in taking a look at what mediation analysis is. And I think that's important here in the context of these trials and in our review, because none of these studies conducted such analysis. Like Francisco said, none of them had patient-reported outcomes. So it would be very interesting if in the future, future studies with better quality could collect both of these outcomes, but not only present them in a table and discuss them separately, but also do some sort of analysis like mediation analysis that would allow you to tease out what's the actual contribution of autonomic nervous system outcomes in modulating pain or disability or whatever else that you're interested in investigating. And for researchers who plan to conduct a systematic review, I think we've learned some lessons from this study we did. First of all, it's important to register your review protocol in a database, and this will soon become mandatory for any review to be published in a decent journal. And currently, Prospero is the main database. The problem with Prospero is that they've been taking a long time to publish the protocols on the website. They have a little staff that manage all the protocols they receive. So it's currently taking 5-6 months from the day you submit the protocol to them up until the point it gets up on their website. And it doesn't go through any peer review process. It's just them accepting and publishing your protocol up there that will give you a timestamp that you can justify to the journal later on that you actually had a protocol before you started the review. So you didn't make any changes in the outcome measures. You are not hiding some outcomes that didn't have a significant effect. And that, because we know that has that's very bad for science when you start spinning results and you start hiding outcomes that might not be as interesting as significant outcomes and things like that. So I think another piece of advice, if we can give any advice to anyone, is that plan things well ahead if you're planning on conducting a systematic review and submitting the protocol. And submit a protocol as soon as possible, because it's going to take a little while for it to be assessed and published.
Those were both great answers, and I can tell by what you're saying that you must have a list of future studies that you're currently working on related to the autonomic nervous system. So let us know, what are those studies?
So this systematic review was conducted during my Master in Science back in 2014. And in this period, in addition to this review, we conducted a clinical trial to assess the effect on pressure pain threshold and heart rate variability of two different approaches of joint mobilization applied to the thoracic spine and a placebo group in asymptomatic subjects. This study was published in 2018, before the systematic review, in the Journal of Bodywork and Movement Therapies. And we did not see any statistically significant effect in favor of any of the interventions in relation to the placebo, neither in the pain threshold or in the heart rate variability. And again, a major limitation of this study was that it was done with healthy participants, and we only had a single session. We also did another trial with asymptomatic participants, again, comparing the effects of thoracic mobilization and thoracic mobilization after an aerobic exercise protocol on the treadmill, on pressure pain threshold and heart rate variability. And the rationale with this study was to see whether the thoracic mobilization could promote additional effects when added to the aerobic exercise protocol, which we know that would increase the sympathetic nervous system activity for sure. And if this excitation in the sympathetic system would be able to reduce pressure pain thresholds. We observed that, in fact, the protocol of aerobic exercise promoted changes in heart rate variability, but we found no additional effects on pressure pain threshold when applied the thoracic mobilization. And once again, the limitation of this study is the sample composed of healthy subjects. And this study is in the final stage of review to be submitted. But now, after those 3 studies, we took a little break from this type of studies. But we really hope that we can see better quality research being done with real patients and collecting long-term follow-up data and using appropriate analysis to understand what's really going on with the autonomic nervous system when you use some kind of manual therapy, and whether this is really relevant to the patients.
I'm certain that there will be more of that evidence coming out. It's always in process, and that's both being thought about and conducted, and then, as you said, reviewed, which can take a while. Hopefully not as long as it took your study when in review.
Yes, for sure.
So there will be further chapters on this topic, no doubt, and I certainly look forward to it when it comes out. I find all of this to be superbly fascinating. And to go back to the general clinical question that I asked you earlier, one thing that I wanted to add, and then it escaped my mind at the moment, I think it's very important for us as clinicians to understand this content, because one of the things we can do with it is we can tell our patients about what's going on. If the patient experiences, for example, an autonomic nervous system symptom, and starts to think that they're maybe losing their mind or something because it doesn't make sense, and then you're able to say, hey, here's what this research says, here's what we know, here's what we don't know, then we as clinicians, and then ultimately as researchers, can be more targeted. And I think it makes the world a better place, because people get to understand the truth, or seek the truth, or just have a better hold on what is or is not going on. And I think that's just, generally speaking, a very positive thing.
Yeah, I completely agree with you, Stephen. I think at the end of the day, what every researcher wants to do is to improve clinical practice and to help clinicians who are at the front treating patients every day, and also patients themselves. And I think, especially for research that even for research that sometimes doesn't seem to be highly applicable to the clinic, you can always learn some lessons from it that you can, and maybe that can trigger your curiosity to go and find some more evidence that can be clinically applicable, or you can, in a way, try to interpret that evidence in a way that's going to be palatable and that's going to make sense for the patient, especially if when we're dealing with complex presentations, and especially when we need to somehow educate the patient, calm things down a little bit. Like you mentioned, patients with autonomic nervous system symptoms that think they're losing their minds because the pain doesn't make sense, the site of the pain, the intensity, the descriptors and quality of the pain. So I guess, yeah, absolutely. What we want to achieve at the end of the day is, like you said, it is a better world.
I think another important message for the clinicians is that if we know that these effects, these neurophysiological effects can occur, we can inform the patient why we are applying a particular technique and what is the ability of this technique to reduce pain, and maybe also this can increase the hypoalgesic effects.
I totally agree. And on that note, gentlemen, we are running out of time. I'd like to say that it's been a pleasure to have you both here on the podcast, and I thank you for all the work that you have been doing and in the future will do for the profession.
Thank you. Thank you very much, Steve. I'm very happy and very honored to be here. And for a researcher, it's amazing when a colleague demonstrates some interest in this work that we have done. Thank you. Thank you again.
Yeah, thanks a lot for having us, Steve. It's been a pleasure being on the podcast, and yep, I hope everyone enjoy it.
I'm certain they will. And on that note, gentlemen, I'm going to, wish you a fond farewell and be well and stay safe.
Thanks a lot. Stay safe, Steve.
Thank you. Thank you. See you again.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.